Okay, so this PowerPoint is going to be over trauma and disaster management. This will be module 9. So obviously with trauma, then we're going to go over different things, aspects within the hospital, and what defines a trauma and the order that you would go about things in managing a trauma. So, first of all, know that there are trauma centers. Certain hospitals have certain accreditations to make them a certain level of a trauma center. So this slide just kind of talks about the different levels, 1, 2, 3, and 4. Not every hospital is a trauma center. And even to get a level 4 accreditation for a trauma center, it's kind of difficult. There's not a lot of hospitals that are actually a level 4. In the Valley, there are a nice handful of level 1 trauma centers, but do know there's certain criteria to make them a level 1, level 2, level 3, or a level 4 trauma center. So when a trauma does come in, there's, like I said, there's an order in which we do things to make sure the best care and the most efficient, fastest care is given um, systematically. So the first thing that will be done is what's called a primary survey. So primary survey is a rapid assessment. They are quickly, very quickly going over anything that's life-threatening. So they'll obviously, this is a trauma. When the patients come in, we're using standard precautions, gloves, gowns, eye protection, things like that. They're, especially if it's a trauma, depending on what the trauma is, they can be very bloody and a lot of bodily fluids. So the staff needs to be kept safe. So they will be using standard precautions. Um, you complete systematically uh, looking at your patient, completing this assessment so life-threatening complications aren't missed. And they'll be using the ABCDE principle to guide the primary survey. So I know you guys know ABC, your ABCs. Now there's ABCDE. So this slide just kind of talks about the ABCDE of that primary survey. It does begin right when immediately that the patient arrives to the hospital. Like I said, the purpose is for a rapid survey to identify life-threatening conditions and then simultaneously have some type of management of these conditions. So we know the ABCDs, and then the E stands for exposure or environment control. So this table is, that A is airway. Here, the assessment, it says airway with C-spine precautions, which is especially important if the airway is not patent. So the first thing that you need to put a quote asterisk around is that you're doing airway and C-spine precautions at the exact same time. One is not before the other. They're done exactly at the same time. So your airway is with trauma, it's airway with C-spine. So those two things go together. B is breathing. So with that, you'll be evaluating obviously the ventilation and putting on high flow oxygen. C would be circulation. You're going to be quickly evaluating perfusion and if there's any bleeding or hemorrhaging. If there is bleeding and hemorrhaging, then you are going to be doing measures that will control the hemorrhage. So that comes in the C with circulation. D is disability. So you're going to be quickly evaluating the neurological status, and you're going to see if there's any resources that are necessary for the care of the patient regarding their neurological status. And then E, like I said, is exposure and environment. This is a complete assessment of the patient, and it says prevent hypothermia. So with exposure, then you're getting to pull out those trauma shears, and as you see them cut off the clothes, that is what you're doing with E for exposure. So you are exposing them so you can see underneath their clothes if there's anything that's going on with that. So this also, you need to think the front and the back to make sure this is quickly identified. And with this, as you know, if you're cutting off clothes, then you can cause even more hypothermia. So you need to make sure that you're being cognizant of that. Okay. The next slide, this is showing the different ways, different maneuvers that you can do for obtaining an airway if you need to do that. The first one is the head tilt chin lift maneuver. In yellow, it says, do not perform this technique on clients who have a potential cervical spine injury. And that speaks for itself because we're moving the head, we're doing the head tilt chin lift and you're moving their head. So if they have a C-spine injury or anything that you would suspect could cause a C-spine injury, you absolutely do not do that. The next one over is a modified jaw thrust maneuver. This is what you will do if your patient is unresponsive and you think that there's some type of suspicion of trauma where it could cause C-spine injury. You're going to do this modified jaw thrust maneuver, and you basically just grab behind their mandible there and you just lift up, and it will pull their jaw forward and open their airway. That's all you do. You're not moving the head at all. You're just pulling the jaw forward. It's hard to do on alert people, but on people that are unconscious and unresponsive, it's a very easy and effective technique. So again, if the patient is unresponsive with suspicion of trauma, and we think that there's some type of potential for a cervical spine injury, we are never going to do a head tilt chin lift maneuver. If that's the case, then we would be doing the modified jaw thrust if they are unresponsive and there is suspicion of trauma. It also goes on to talk about that you can also use other adjuncts like an oropharyngeal airway or a nasopharyngeal airway. A bag valve mask with 100% oxygen is also indicated for clients who need additional support during resuscitation, and until an advanced airway, like an ET tube, is established. So if the patient is spontaneously breathing, though, we don't have to bag them. We can just use a non-rebreather mask with 100% oxygen. This right here shows a hard collar immobilization or a Miami device. So if somebody comes in with a suspected or potential C-spine injury, then right away they're putting them into a Miami brace until we can get that ruled out. So, or maybe they do have C-spine injuries, so they'll just stay in that device, which you can see would be not that comfortable. So, but you do need to make sure that if you have a suspected cervical spinal cord injury, it's essential to put this Miami brace on them or something similar to that to have that immobilization, because we could cause you could actually cause further injury, devastating injury, paralysis to the patient if you move their head around. So the patient should be immobilized with a hard collar until a spinal cord injury is ruled out. All right. After the airway, then just going to kind of go through them, the ABCDEs. So after the airway is B, breathing. We've established a patent airway, then we also need to make sure that we have chest expansion, chest rise. So we're watching for respiratory effort, chest rise and fall. We're identifying if there's any chest trauma. We're making sure our trachea is midline. And then it goes on to say to assess for JVD and note the rate and depth of respirations. It says if the patient is not breathing or breathing inadequately, then we would manually ventilate the patient. And I already kind of talked about that with a bag valve mask and supplemental oxygen or something like that until we can get some type of airway so that they're able to breathe. So all trauma patients should receive oxygen via a face mask and placed on pulse oximetry to properly measure their oxygenation. Chest x-rays are done to look for life-threatening chest injuries. And then, of course, lab work like ABGs, things like that. We will be doing that. Okay, next is circulation. So once we have adequate ventilation, then circulation is assessed. So we'll be looking at the heart rate, blood pressure, pulses, cap refill to check perfusion. If they're having some type of cardiac arrest or something like that, and if hemorrhage is there or something like that, then we're going to have to address that at this time. So if there's hemorrhage, we're going to do something to control the hemorrhage. And obviously, if there's cardiac arrest, then we're going to be doing CPR. We also have to remember that shock could happen. So it can develop at any time. Shock is the body's response to inadequate tissue perfusion and oxygenation. And as we know, as we've already had our shock module, we know that compensation, that part in the shock process will have an increased heart rate and hypotension can ensue at any point. So we need to really this is where if we do need to do CPR, we would be performing CPR. As far as the hemorrhaging, if the patient is hemorrhaging, this is where we are going to apply direct pressure. If we can see it, if there's any visible significant external bleeding, then we would definitely be providing direct pressure. So remember, this is still in our primary survey, and we would be taking care of that during the primary survey. We would also obtain IV access during the primary survey, during the circulation part, and we'd be getting probably 2, but 1 to 2 large bore IV catheters. When I say large bore, that's 18 gauge or larger. And they put them right into the AC of both arms, unless there's some injury there. And then the fluids that we would be giving would be, we would be infusing isotonic IV fluids like lactated ringers or 0.9% sodium chloride. And if they're hemorrhaging, we may be giving blood products. But that's what would be going on during the circulation portion of the primary survey. So this slide just kind of talks about, we've talked about it before, but fluid resuscitation. There's evidence-based practice that shows that for for, 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 have been seen by using this one-to-one-to-one method. So it says first, they first minimalization of crystalloids, and they use to minimize that, then the use of crystalloids like lactated ringers or normal saline, that instead will be using one-to-one-to-one, so one blood product ratio, like packed cells to one FFP to one platelets. And that's what they will be doing instead of just giving tons of crystalloid or normal saline. They also will be allowing for permissive hypotension, and they have shown that this has actually shown to reduce mortality. Okay, next in our ABCDs is D for disability. And it says this is a quick assessment to determine the client's level of consciousness. There's a couple different things that you could use to figure out disability. So here it talks about AVPU. You can use AVPU mnemonic, or you can use a Glasgow coma scale. So AVPU is A for alert. The V is, oh, just a second, guys. I'm sorry, but my daughter can't get in, so I'm trying to open the garage. Again, I apologize. And of course, it's not going to open. Anyway, A is alert. The V is responsive to voice. The P in AVPU is responsive to pain. The U is unresponsive. So the GCS, that scale is going to be the next slide, but obviously that's your eyes, verbal, and motor that you're assessing. So let's go look at that again real quick. So here's the Glasgow coma scale. So eyes, that's your eye opening response. So 4 is spontaneous, and you can read the rest of that. V, your verbal response, if they're oriented, they get a 5, and their motor response, if everything's good and they follow all commands like that, then they get a 6. Okay, and I apologize. You're gonna have to hold on for 1 second because I got to go let my daughter in. Hold on. Okay, I'm sorry about that. I apologize. Okay, so anyway, as you can see with this GCS scale, that the best score you can get is a 15, and then the lowest score you can get is a 3. So anyway, you guys, we've talked about this a lot. So that's your Glasgow coma scale. Okay, then we go on to E, exposure. So I told you with this, we need to, this is when we're getting out the trauma shears. So we need to remove all of the clothing for a complete physical assessment. an environmental priority intervention is to control the environment to prevent hypothermia. So during this time, warming blankets, warm fluids, monitoring of the temperature is essential. We've already talked about what hypothermia can do, and in trauma, that's part of the whole trauma triad of death. So exposure, remove all the clothing. It says you may need to cut off the client's clothing. Clothing is always removed during a resuscitation situation to assess for additional injuries or those related to chemical or thermal burns involving the clothing. Preserve items of evidence. Do not cut through bullet holes. So you have to be aware of that. So like I said, hypothermia is can be very dangerous. So this is a big concern with trauma. Victims of trauma are at a risk due to exposure, unwarmed oxygen, cold IV fluid, all of that. So in order to prevent hypothermia, it talks about removing wet clothing from clients and covering them with warm blankets. And we can also increase the temperature of the room. We can also use like a heat lamp, warmed IV fluids, something like that to help with preventing hypothermia. So the trauma triad of death, I kind of threw it in last week's lecture as well, just so you really kind of get a good understanding of it. This exact slide is in last week's lecture. So trauma triad of death, hypothermia results in peripheral vasoconstriction, which decreases oxygenation, causing hypoperfusion and lactic acidosis as well as a coagulopathy. And then it says the acidosis also results in decreased myocardial performance. So this is a lethal combination of hypothermia, metabolic acidosis, and coagulopathy that can be found in the trauma patient. So of that, hypothermia is an extremely preventable contributory factor. So we can definitely control hypothermia. Hypothermia, it says, is caused by a number of factors like massive hemorrhage, sepsis, exposure, fluid resuscitation without warm fluids, and certain medications like muscle relaxers, sedatives, opioids. And then, like I said, this trauma triad of death, uh, this is starting and it starts going, then you can have a code situation definitely on your hands. Okay, so after all of that, then we're going to start our secondary survey. So we're done with the primary survey, which was done very fast. Now we're starting on our secondary survey. And during this, we do further things like laboratory imaging, ultrasound, any other diagnostic studies. This is what we do. A valuable tool that they use during the secondary survey is a FAST assessment. So this is a focused assessment with sonography for trauma, FAST, FAST assessment. This is an ultrasound that they used. Sonography is ultrasound. So it's an ultrasound that they use to look for free fluid in the abdomen, pericardium, or pelvis. And if we have a FAST examination that's positive, then that typically usually means that there's blood present, and the patient with a positive FAST would be requiring emergency surgery. So emergency surgery would be done to find the source of bleeding and repair the injury. So that means they go straight from the trauma room straight to surgery if they think there's bleeding. And if you remember in our skills lab, we showed a video, a couple scenarios of trauma scenes where they did do that. They took that lady straight to surgery and it saved her life. So Other things that they could do during the secondary survey would be things like placing a Foley catheter to watch our urinary output and renal function. They could insert a gastric tube to empty out the stomach and prevent aspiration. So they could do that stuff during the secondary survey. Also during the secondary survey, after they get done with this stuff, at this time, they will also be gathering further information from like the patient or pre-hospital providers, or maybe there's witnesses there that will give information, but they will be gathering further information during the secondary survey. So here, this just kind of shows what um, that whole secondary survey can kind of look at with a FAST exam. So it shows if there is abdominal trauma, they have an unstable patient, they do a FAST exam. If they have a stable patient, they do a FAST exam. If they have an unstable patient and their FAST exam is positive, then off to the operating room they go. They go right away. They don't mess around. If it's negative, then they can go to CT scan. If they have a stable patient and they're stable and they're fast positive, then they can go and have a CT scan and see what's going on. And then if it's negative, it says stop, repeat fast, CT, or anything else that they need to kind of look at. But this is just kind of, they're showing the process of this. And this has to do with what is called damage control surgery. So I told you if there's hemorrhaging that they're going to take them for emergent surgery. It's called damage control surgery, and it's indicated for trauma patients that present. It says they present or they're at the point of death and require immediate surgical control of hemorrhage and contamination. So this is also evidence-based practice that was started in the military, and it shows that it has increased survival rates in people that are having severe hemorrhagic shock by 50%. So it says it uses a staged surgical approach after initial resuscitation, avoiding long, complicated procedures, so on and so forth. Excuse me. But it says the philosophy of this type of management is to abbreviate surgical interventions before the development of irreversible physiological endpoints, like avoiding or correcting the lethal triad of hypothermia, acidosis, and coagulopathy. And it goes on and talks about that. So this is called damage control surgery. It's done during the secondary survey. If they are unstable and they are fast positive, then they go off to the operating room to have their damage control surgery done. Okay, so here's your connection check question. A nurse understands damage control surgery is performed for which of the following reasons? And this is a SATA. So A, control hemorrhage, B, prevent renal failure, C, prevent contamination, D, avoid further surgery, or E, control hypoxia. And as you can tell in your speaker notes, the answer is A and C. So A, control hemorrhage, and C, prevent contamination. So damage control surgery is done to control bleeding, prevent contamination, and perform temporary wound closure as necessary. The patient is then treated in the ICU to correct any physiological abnormalities before further treatment or surgery is done. So you can read the rest of that in your speaker notes. Okay, so now we're going to go on to another part of trauma. So we're done with, I think, aren't we? Yeah, we're done with the primary and secondary surveys. Now we're just going to start looking at things that can cause trauma. So this is mechanism of injury. So this slide, we're talking about blunt trauma, blunt thoracic trauma, and blunt cardiac trauma. And it goes on to describe these things and talk about them. So with blunt trauma, there's not an opening or anything. So a lot of times it is very difficult to see. This could be caused from any deceleration, acceleration, compression, or shearing activities. So it says deceleration, that's when we come to an abrupt stop. Acceleration is when there's a sudden increase in speed. And like maybe if you're driving in a car and it hit a brick wall, like that would be a good example of deceleration. So all the passengers inside the vehicle come to a sudden stop and hit the hard surface in the car. Another thing could be like an example of an acceleration would be a pedestrian standing in the street and they are hit by a moving vehicle, causing the pedestrian to be thrown 20 feet. So that could be that. Compression injuries, or organs or tissues are compressed between two immovable surfaces, like maybe bones in a steering wheel, or God, it's kind of sad that I even have to say this, but I had a cousin 24 years ago who was working on a farm equipment and a grain truck, and he had the back end of the grain truck elevated up. I was working on the hydraulics and had blocks even there to help, and it still came crashing down and it crushed him. He was leaning in, so half of his body was crushed by the grain truck. And he was killed. He was alive for a bit, and they got it off of him, and they took him to the hospital. But his injuries were so extensive that he died. But that obviously is a crushing injury that would occur. Shearing occurs when skin or tissue slides in the opposite but parallel directions. So that's what shearing is. So then we go into blunt thoracic trauma. This is some of the most life-threatening injuries. This occurs with the heart, lungs, and aorta. And actually, with my cousin, it did that. It just crushed it crushed his chest, but his aorta was the big deal there. So this is when well, that makes sense of what it is. So that's what blunt thoracic trauma is. Basically, just the example that I gave you. So blunt cardiac injuries. So you can have a myocardial contusion, cardiac rupture. You can have exsanguination when you bleed to death, or a traumatic aneurysm. So these are some different types of blunt cardiac injury. So again, the exsanguination means an extreme loss of blood volume. You can have a tear or something like that, especially like in the aorta, or if you have an aortic aneurysm. You can also just have a rupture, complete rupture of the aorta, and that will cause people to immediately die, an aortic rupture. Okay. Another slide talking about mechanisms of injuries. We have blunt pulmonary injuries. This could be rib fractures, pneumothorax, hemothorax, pulmonary contusion. One thing with the rib fractures I want to kind of talk about is a flailed chest. So rib fractures and flailed chests can cause a pneumothorax or a hemothorax. Remember, the hemothorax is blood. So especially when the sharp edges of the broken ribs, if they perforate the chest wall, this can cause, this loss of negative pressure causing this hemothorax. So this can cause, like I said, a partial or total lung collapse. Once a pneumothorax has developed, then there's tension pneumothorax that we talked about, that's a medical emergency. That might occur as well. So a flail chest is when you have many broken ribs in a row and the entire chest is moving up and down. So a lot of times they'll talk about a paradoxical chest wall movement. This could be indicative of a flail chest, the entire like four or five, like five ribs broken all in a line. Then that entire portion of the rib cage is moving up and down. So that's called paradoxical movement, and that can be indicative of a flail chest. All right, blunt abdominal injuries. Blunt abdominal injuries could be compression injuries, shearing injuries, or pelvic fractures. And then again, and then it's same thing but it's in your abdomen. And then you have penetrating trauma, which could be gunshot wounds or a stabbing, like if someone stabbed you. Um, when you're thinking about motor vehicle accidents and things like that, just know that you can have a lot of these compression injuries that can occur um, because you have the seatbelt on and the seatbelt is like restraining them, which is good. You want that, but it can also cause a lot of damage. So sometimes safety restraints like the seatbelt provide significant protection, but when not used correctly, they can cause injury. If the lap belt of the seat belt is not placed correctly, it can actually cause shearing injuries to the lower abdomen, like rupture of the small bowel or bladder or even the colon. So those organs, if you come to an abrupt stop and that lap belt isn't where it's supposed to be, those organs they'll just move forward beyond the lap belt. So that's where you get the shearing. So be aware of that with the lap belt, that those can cause injuries as well. Okay, and then the gunshot wounds, when we talk about penetrating trauma and like knives, guns, ice picks, anything like that. One thing to be, and actually, it can even be things like glass from a broken windshield that can cause penetrating trauma. But with gunshot wounds, you need to remember that bullets do not typically travel in a linear fashion once they enter the body. So the direction can change. They can hit because of the density of the tissue or maybe hitting bone or anything. But this direction changing that happens with bullets, this leads to unpredictable trajectory and potential injury to multiple structures within the body. So you need to know that that bullets do not travel in a linear fashion once they enter the body, and they can have very unpredictable injuries to multiple different structures. So um, be aware of that too. Okay, here we're going to talk a little bit more about the flail chest. So flail chest, like I said, is paradoxical chest wall movement. On inhalation, the damaged area inward, and on exhalation, the damaged area moves outward. So it says the flail chest is defined as three or more adjacent ribs that have been fractured in two or more places as a result of a blunt or crushed chest trauma, resulting in a free segment of the ribs. So this paradoxical chest wall movement is a hallmark sign associated with a flail chest. And like I said, with each inhalation, the damaged area moves inward, and on exhalation, that section of the chest wall moves outward. As with rib fractures, chest wall movement is compromised largely because of pain, and they'll have insufficient respiratory efforts. Okay, so that is your flail chest, and know that that goes with paradoxical chest wall movement. I think I've said that probably 4 or 5 times now. Okay, tension pneumo. A lot of this is just kind of review a little bit. We've already gone over a lot of this, so I didn't put a lot of stuff on it. So tension pneumo, we said, is accumulation of air or blood in the pleural space, may result in a mediastinal shift and tracheal deviation towards the unaffected side, causing compression of the heart, vena cava, aorta, and unaffected lung, and ultimately your patient's going to code and die. So it causes cardiac tamponade. So tension pneumo, TP, tension pneumo, tracheal push. It pushes the trachea to the unaffected side. When this is going on, that tracheal deviation toward that unaffected sign is a hallmark sign of tension pneumothorax. It's life-threatening, like I said, because it's impeding the heart, and you're having reduced cardiac output and everything because of that. It's causing this cardiac tamponade. In emergent cases of tension pneumothorax, a needle decompression is performed to remove the air from the pleural space. They take a large bore, like a 14 gauge needle, and they insert it between the ribs, and they remove that air or blood. And then that is immediately followed by a chest tube insertion. So yes, they can take, like I said, they can take this, they can do a needle decompression, but then they will be following up with a chest tube insertion. So as the nurse, then we know that we are going to be ready to get this set up so they can do a chest tube insertion. And then in your speaker notes, again, it goes on chest tube management. We've gone over this multiple times with you guys, but, obviously keeping the tubing free from kinks or loops, because that in itself could cause a tension pneumo. We don't want to do that. And we don't clamp the chest tube unless there's an order for it. And then obviously afterwards, if anybody that has a chest tube, and or if they're even getting close to having it removed, we want to make sure that we're giving pain medication, we're ambulating them, we're doing a lot of pulmonary toileting to help assist them to be able to breathe effectively. We're encouraging the use of an incentive spirometer every 1 hour while awake. So that IS, the incentive spirometer, this is important to do for patients with a chest tube. Okay, some of the complications of trauma are 3 main ones. Actually, there's 4, but the 3 right here is hemorrhage, airway compromise, and sepsis. So hemorrhage is the leading cause of preventable death after injury if not controlled. Hemorrhage is very, very serious and very common complication of trauma. And then, like I said there, it's the leading cause of preventable death after injury if not controlled. It's the most common reason for death in trauma clients in the first 48 hours is hemorrhage. So, obvious causes of hemorrhage include, anything the abdominal or pelvis or chest trauma, including organs and vessels, and then long bone injuries. The major sources of abdominal bleeding in blunt trauma are injuries to the spleen and liver. And then both organs are very vascular and prone to shearing and lacerations. So we would always, I said that it's the most common reason for death in trauma clients in the first 48 hours. So you would always continue to monitor the client for delayed signs and symptoms of internal hemorrhage. It's very, very important after a trauma. Airway compromise, it says direct damage to the airway, injury to the surrounding tissue, or secondary injury such as decreased level of consciousness could cause airway compromise. And then sepsis, potential complication for our injured trauma patient because of the activation of SEERS. So the systemic inflammatory response. So injuries themselves and the invasive interventions that we need to do to treat the injuries can reduce or can introduce infection risk. So trauma itself is thought to be one cause of the initiation of a systemic inflammatory response, which is SEERS. Recognizing the signs and symptoms of sepsis and treating it early can help prevent serious complications of death. Okay, so again, just kind of looking at this, our nursing interventions to help alleviate or control those complications of trauma, therefore, are your ABCDEs. And then this goes on to talk about that. We've already talked about all of this in pretty big depth. So those are your nursing interventions and assessments. And again, in your speaker notes, I would read through those and making sure you understand it. Now, another complication, I said that there's basically four, and there are. The fourth would be fractures. So I just want to kind of talk a little bit about fractures. This slide, you don't need to know all these different types of fractures, but just know that this is why I'm just trying to show is that there are so many different types of fractures. So, and then especially if you have elderly patients or anybody with any type of chronic illness, then just know that they're more susceptible to this. So one big thing though, with hemorrhage being a serious and common complication of trauma, just know that fractures, there are certain fractures that can lead to hemorrhage. So that's what I'm trying to show. So like I said, hemorrhage is a serious and common complication of trauma. It's the leading cause of preventable death after injury if not controlled. And pelvic or femur fractures can be a source of major hemorrhage that needs to be controlled by stabilizing the fractures. So if you have anybody that has come in with a motor vehicle accident or a pedestrian getting hit on the street by a vehicle being thrown, if we're thinking any type of pelvic or femur fracture, that is a major source of hemorrhage. As we keep going here, actually, I'll talk more about it in a second. I have a couple more slides to show you about these fractures. So here it just talks about non-medical treatment or management for fractures. They can do closed reductions. They would also manipulate and realign the bones. Then they can do surgical open reductions. They can do internal fixations, external fixations. This next table, though, this shows you just how significant the blood loss can be from fractures. So it goes on to show like rib fractures and then the ulna, radius, tibia, and fibula. That's getting up there. You can lose a liter in that. And then look at that femur fracture, 1,500, and then a pelvic fracture, 1 to 3 liters of blood loss. I mean, that's almost all of your blood volume when you get up to those 3 liters. So they can have what's called that retroperitoneal hematoma or an RP bleed, retroperitoneal. It goes to the back. You can see it into their back. So those pelvic fractures are no joke. It's a major source, pelvic and femur, but a major source of major hemorrhage that needs to be controlled by stabilizing the fracture. So what I was kind of telling you is like keep in mind with trauma, especially motor vehicle accidents and so on and so forth, I've kind of talked to my class, I believe, about a motorcycle accident that I was in my bedroom, and my husband and I were both up here, and we heard out on the corner, we live on a corner, and we heard this screeching and then a crash. And it was in the middle of the day. I looked out the window, and sure as enough, it was a motorcycle um, person on a motorcycle that got hit by a vehicle. So I grabbed gloves, and of course I have them here because I dyed my hair purple. And I grabbed my gloves, ran out the house, and ran over there. And this guy, it was awful. So not only was there blood obviously coming out of his face, um, he was knocked unconscious. He was on his stomach, and then his head was to the side. His airway was becoming obstructed, and his face was turning blue. We did try to maintain as much C-spine as we could, and we flipped him over. And he had definite paradoxical chest wall movement. I lifted his shirt up, and it was awful what I was seeing there. I could also, he had his right arm very obliterated. And then as I was feeling his legs, his left leg up in the thigh was significantly bigger than his right. And right there, I was like, he has a broken femur or pelvis. That was not good. And ambulance came, took him off. I have a coworker who is works at a trauma one level one facility. She got that trauma call, and when I talked to her about it, he left. He had woken up and was moaning and was actually screaming, and they were trying to control him. But my friend told me that she's pretty sure that he passed away, and it wouldn't surprise me. And it was probably because of that hemorrhaging. I mean, it could have been the head trauma and everything, but honestly, I was blown away by how big that thigh was. So that's my little story. Trauma hemorrhaging, just make sure you know that pelvic and femur fractures are a major source of hemorrhage. Okay, and then this slide just kind of goes over other complications that can happen from fractures. Again, you guys can read through those speaker notes, but a lot of them make sense, from neurovascular compromise, from lack of blood, decreased blood flow. You can have thromboembolisms happen. You can have a fat embolism from long bone fractures. Um, it says traumatic rhabdomyolysis, so compression and tissue ischemia happening, then myoglobin spilling into the circulation. And as you know, when that rhabdo happens and that myoglobin spills over, then it clogs the nephrons of the kidneys, and they go into renal failure, acute tubular necrosis, so ATN, and renal failure. And then hypovolemia speaks for itself because of the blood loss, infection, especially if it's open fractures. And then malunion and non-union. So fracture fail to heal in correct alignment. That can happen, or they just fail to heal altogether. Okay, so here's another question for you. Um, a 30-year-old driver who was in a front-end high-speed motor vehicle crash is admitted to your ED. They were wearing a seatbelt, but the car did not have any airbags. There was severe front-end damage with spidering of the windshield in front of the driver's seat and a bent steering wheel. As a nurse caring for this patient, you should anticipate and monitor for which injuries. So it's A, B, C, or D. As you look through this, um, see which ones you think would happen. So the answer would be B, the head and cervical spine. So sternal and rib fractures would be expected due to the force of the impact the patient's body had with the steering wheel. and then the force was great enough to bend the steering wheel, making there be a very high index of suspicion for a sternal fracture and rib fractures. And then it says, with such a high force chest wall injury, a cardiac contusion must also be suspected, and the patient will need to be monitored for cardiac dysrhythmias. Spidering of the windshield takes great force, and with it being directly in front of the driver's seat, the cause of the spidering is most likely the driver's head, and therefore that should be a high index of suspicion of head or brain injury. And then that also puts the patient at greater risk for a C-spine injury due to the deceleration or whiplash forces. So you guys can read back through the speaker notes on that and take your time with it so you understand it better. Okay, another question. The trauma nurse anticipates which of the following complications when treating a patient who is intoxicated and was hit by a car while walking. The patient is in a C-spine immobilization, has an open femur fracture, a pelvic fracture, abdominal tenderness, GCS of 12, select all that apply. So A, B, C, or D. And here we see an open femur fracture and pelvic fracture. So A makes 1,000,000,000% sense. Then it says decreased SpO2. Both the fact that the patient, it goes on to say, so it's A, B, and D. So A, because of the femur fracture and pelvic fracture. And then it says abdominal tenderness indicates potential liver or spleen injury, which further increases the risk for bleeding. Alcohol and the bleeding can easily cause the patient to vomit, putting the patient at great risk for aspiration and decreased SpO2. The patient's low GCS score puts the patient at further airway risk since it is unknown if the GCS is alcohol induced or secondary to head trauma. And then sepsis may be a potential eventual complication for this patient secondary to the open femur fracture that allows for a source of infection. And sorry about that. The E, I forgot to put down one level, but so the answer is A, B, and D. Okay, onward. Compartment syndrome. Compartment syndrome, I told my classes that this was not part of your content outline, and to please write it in to your content outline for the next exam, compartment syndrome. So there will be some questions on that. So compartment syndrome is rare but serious complication that can cause permanent loss of the affected limb due to neurovascular compromise. And it doesn't even have to be a limb because, as we've already talked, it can even be your abdomen. It can be anywhere that's causing this crushing symptoms to happen where they're not allowed to expand. So, compartment syndrome, when you're thinking about limbs, though, this could be like something caused from a cast can be compartment syndrome. So what are some examples that can restrict circulation? It could be a cast. We talked about burns this last week, and we talked about how you would have to do escharotomies because that eschar tissue can make it so the chest wall cannot expand and help with ventilation. So circumferential burns, burns that go all the way around, can cause compartment syndrome. Bleeding into a cavity. Sometimes when people go to surgeries for abdominal surgeries, things like that, they'll have to keep them open when they return and not close them all the way because there's so much swelling and bleeding that occurred within that cavity. So symptoms of, there's 6 Ps for compartment syndrome, and those are the most common symptoms of compartment syndrome, the 6 Ps. So pain out of proportion to the injury, pallor, pulselessness, which is actually a late sign, and that can never happen because if that does, you're done. It's not good. Um, Paralysis and paresthesia. So, did I do them all? Passive pain at rest, along with pressure, paresthesia, pallor, paralysis, and pulselessness. So it's up there in your speaker notes. You can look at them. So the 6 Ps, um, passive pain or pain out of proportion to the injury, um, pressure. Oh, that's what's missing. Pressure, paresthesia, pallor, paralysis, and pulselessness. So it looks like my P's there, I forgot to put pressure on there. So that should also have pressure. Okay. Um, you will have about 6 hours to relieve this pressure, and this is done with a fasciotomy. We talked last week with burns that when they would do that, that's called escharotomy. When they cut through the eschar, it is a fasciotomy, but it's called an escharotomy. So a fasciotomy is one thing that we do for compartment syndrome to alleviate this. Here's a picture of a fasciotomy that they're doing. And then also back on here, you guys can click on this YouTube link and it'll show you a video of them doing a fasciotomy. It's actually a pretty good video, so I would encourage you to watch it. So this is just a picture of a fasciotomy. So here's your evidence-based practice talking about compartment syndrome. And just know that if this is going on, then the nurse needs to perform frequent neurovascular exams that include assessment of both the affected and unaffected limbs. So CMS checks need to be done and are very important, checking the circulation, temperature, movement, sensation of both the affected and unaffected limbs. And then, like I said, the 6 Ps of compartment syndrome, but the nurse definitely has to do those frequent neurological assessments. Just real quick, we've already had head trauma, so this is just going to kind of be a recap of head trauma, which can obviously happen in trauma. So this is the coup, counter coup that is shown to cause these shearing that can happen with any type of head trauma, and to kind of be aware of that. So we can have skull fractures, we can have closed skull fractures. We don't know what's really going on. So the most important thing is that these patients will definitely be having a CT computed test, the CT of the head. So this is the initial diagnostic test that's performed with traumatic head injury. This diagnostic tool offers rapid, convenient, and non-invasive visualization of structures. So it's very important to have a head CT done. Um, we already know that if we have head injury, that we will be doing watching for any signs or clinical manifestations of increased ICP. We'll be doing uh, frequent neurological assessments, and we have to perform these frequent neurological examinations to make sure that we are vigilant to any type of subtle change in level of consciousness that could happen, because we want to be ahead of the game. So we want to be able to act and intervene to make sure we don't have furthering increased ICP, which could actually cause more damage. So we don't want that, like herniation. Always keep in mind, especially with trauma, when these patients come in, they're having obviously a lot of pain. It's important to keep in mind that a neuro exam is going to be complicated with the use of any medications to like narcotics and things like that to treat pain. So that may end up preventing an accurate neurological assessment if we're giving narcotics. A lot of times when people come in for trauma, they don't give them any narcotics. They are in pain. And it's because they don't want to skew this neurological assessment that they have to do. So just be aware of that. Okay. So much with that. Let's go into poisoning. So, with poisoning, obviously, it could cover a lot of things. The most common poison exposures are due to analgesics, cleaning substances, cosmetics, foreign bodies, plants, sedative, hypnotics, and antipsychotics, cough and cold medications. Fatalities most commonly result from the ingestion of analgesics, sedative hypnotics, antipsychotics, antidepressants, street drugs, obviously, cardiovascular meds, or alcohol. So, again, look through your speaker notes. They kind of divide these main ones out and talk about them. And who's most, your typical demographic for these types of poisonings. So some nursing assessments and interventions. Obviously, we're going to be having a risk of airway or breathing patterns and risk for aspirations with these patients. So we're going to be monitoring our vital signs, obviously, our pulse oximetry, our neurological assessments for level of consciousness, and continuous cardiac monitoring, especially with things like cardiac meds like beta blockers and stuff like that. We can have dangerous dysrhythmias. With We can have depletion of potassium levels with salicylate poisonings and different other medications that can cause potassium changes. So watching for those cardiac dysrhythmias is important. Um, so labs that we'll be doing is, toxicology screen, ABGs to watch our acidosis and alkalosis, our potassium levels, glucose, liver function tests, and so on and so forth. Some interventions that we can be doing is always we're going to be managing our airway, establishing an IV. We already talked about the ECG monitoring and then giving whatever medications are ordered. Now, there's different medications that they do for different things. So, in your speaker notes, it really does talk about them. We know like IV fluids and thiamine for alcoholics that or people that have alcohol intoxication, but especially alcoholics. Benzodiazepines, flumazenil that will be an antidote for a benzodiazepine overdose, sodium bicarb. But one thing that you're going to see a lot is this N-acetyl, I can't even say this. I call it NAC. So, or mucomist. N-acetylcysteine. Thank you. N-acetylcysteine is also known as mucomist, and also known as NAC or NAC. So this is an amino acid that's given by typically if it's an overdose of something, we're giving it IV, and it's to prevent or minimize hepatotoxicity, specifically with acetaminophen toxicity. So people that usually teenagers, usually girls, would overdose with Tylenol. So we will also get a serum acetaminophen level and LFTs, liver function tests, but they will put them on N-acetylcysteine, otherwise known as Mucomis or NAC, but N-acetylcysteine drip, continuous infusion, and they do 3 bags, and it's a whole production on how they give it. Another drug that you'll see a lot is activated charcoal. So it says it's a decontamination agent that works by binding with the poison, preventing or slowing absorption into the system. That's another thing you'll see is activated charcoal. And my lovely little daughter did chug-a-lug some activated charcoal when she was like 3, taking a nap at my mom's house. I had her in a playpen, and my grandma was over visiting and had all of her meds sitting up on a dresser. And my daughter woke up from her nap and proceeded to pull all the meds into her playpen and open them all up. Now, I didn't know when I went and checked on her if she had taken any of those meds, and some of them were cardiac meds, so on and so forth. So I gathered them all up and took her to the ER, and they were going to put down an NG tube and give her activated charcoal. And I said, actually, just give it to her in a cup. I swear to God, she'll drink it. She likes food and likes everything. They didn't believe me. They finally did it. They handed it to her. They said that she would never drink it, and she did. She drank the whole thing, got done, held it out to them and said, more? She wanted more. They couldn't believe it. So activated charcoal with her teeth all full of black charcoal. Activated charcoal is something that you'll see a lot, and N-acetylcysteine is something that you'll see a lot as well. Okay, the nurse is caring for an unconscious patient coming into the ED after taking an overdose of an unknown substance approximately 1 hour ago. Which of the following actions should the nurse take? A, initiate gastric lavage. B, which should the nurse take first? Sorry. Initiate gastric lavage. B, insert 2 large bore IVs. C, assess vitals with pulse oximetry. Or D, insert a nasogastric tube. So your answer is C. So the rationale says weak or absent respirations or low oxygen levels require immediate intervention before initiating interventions directed at an overdose. So always assess first. So C, assess vital signs with pulse oximetry. Next one. It says the nurse is caring for a patient who arrived in the ED with a temp of 105. For the last 3 days, the area has had a heat wave with temperatures higher than 100. This patient was found in their apartment, which did not have air conditioning. Which of the following actions should the nurse plan to take first? A, apply cooling blankets. B, obtain lab specimens. C, establish IV access. Or D, administer Tylenol. And the answer is A, apply cooling blankets. So the rationale, there should be an emphasis on cooling the patient. The longer the patient remains hyperthermic, the worse the prognosis because of the damage to the patient's organs. And then you can read the rest of it there in your speaker notes. And then the next one, this one is too hard to kind of verbally do. So I'll let you guys do this one on your own. Okay, disease management. So now we're going into, or I'm sorry, disaster management. We're going into the disaster. So disaster management, it says, per the WHO, a serious disruption of functioning of a community or a society causing widespread human, material, economic, or environmental losses which exceed the ability of the affected community or society to cope using its own resources. So in your speaker notes, it goes on to talk about FEMA, the Federal Emergency Management Agency. They say that their definition of a disaster, what that is, there's also a website there that's straight out of your module, actually. That website to look at disaster management. It's actually a pretty interesting website. And then there's different definitions here by different uh, governmental agencies. So you guys can look through that. Basically, it says the three main characteristics are an event of destructive magnitude, two, that kills, injures, or causes human suffering to a significant number of people or the environment, and three, that requires the need for external assistance. And again, this can be natural or man-made. So some of the recent disasters that we've had, obviously our COVID-19 pandemic. We have had been seeing civil unrest just over there, with Israel and so on and so forth. Also, the Ukraine. Mass shootings we unfortunately see all the time, hurricanes, heat waves, and then the southern border refugees. So it talks about how the COVID-19 pandemic was probably the first time in US history that every US emergency manager was working on the same crisis, and nearly every emergency operations center was open and activated. So COVID-19 pandemic, there's just not enough words to describe the horror that we saw with that. Okay. Mass casualty incident. This is any large-scale event in which emergency medical resources such as supplies, medical rescue personnel, or equipment are overwhelmed by the number and severity of casualties, thus requiring prioritization of medical care by triage. So, good example of this are any mass shootings. So when they had that mass shooting in Las Vegas at that music festival, that was a mass casualty incident, and they did institute these triage I want to say models that I'm going to talk about coming up. I actually had a friend that called me from Las Vegas, and he used to work with me, and he was called in and had to do this mass triage. He's a PACU nurse, and he was called in by his hospital to go to the ER immediately, and he was one of them accepting these people that were at that Las Vegas shooting during that music concert. It was awful. So the big thing with this is the goal of disaster triage is to ensure, quote, doing the most good for the greatest number of people. So that is the goal of mass triage. So with disaster triage, you have an allocation of limited resources in a disaster. You have the right patient, right place, right time, right level of care. So the whole goal of daily triage is to identify and treat the most seriously ill or injured first. So on a daily basis, the ERs do some form of daily triage. They have a triage section, and this is what they're doing to make sure that there's not a delay in care for the most critical. Simple triage and rapid treatment. This is there's a couple different triage models. So this is the simple triage and rapid treatment. This is the START, STRT, so START. And then there is also the next slide we'll talk about sort, assess, life-saving interventions, treatment, and or transport, which is SALT. So with the START method, with this method, we have 3 basic observations: respirations, perfusion, mental status. So with this, we have the minor that are tagged green. These people can ambulate, follow commands. They obviously have perfusion. They can stand upright. Patients with no spontaneous respirations. These patients will have their airway repositioned, and then if there's just one time, and if they're still not breathing, then they are black labeled or tagged deceased. If with that repositioning, if they start breathing, then we immediately tag them a red. They're tagged red or immediate. That means that they're the ones that are going to be seen immediately. Remaining patients are delayed or yellow tagged. So there's 2 interventions that can be done during the start uh, model, and that is number 1, we can hold direct pressure to control bleeding, and then just like I said, we can do a basic airway management. Okay, so this is your start, another slide of your start algorithm. So like I said, this is one of the most popular triage systems in the United States. And this kind of, you can read through your speaker notes here, it kind of goes in more in depth about it. But the big thing to take away with this is the red triage. So I said that if people, if they have to, if there's no respirations, they will reposition the airway. If that repositioning initiates respirations, then those patients are tagged red or immediate. Patients with respirations greater than 30 breaths per minute or capillary refill longer than 2 seconds or lack a radial pulse or are unable to follow simple directions are also tagged red, triage tag or immediate. The remaining are tagged delayed or given a yellow tag. So those immediate ones, be aware of that red triage with the start. The next model that we have is called, like I said, it was SALT. So sort, assess, life-saving interventions, treatment, and or transport triage. This is your SALT model. This has a first priority is for those who cannot follow commands and have obvious life threat. Second priority goes to those who cannot follow commands but cannot walk, or I'm sorry, who can follow commands but cannot walk. And then third priority are those who are unable to walk. So again, this next slide kind of shows the algorithm and give a little bit more in depth on it for the SALT method. But with the SALT system of triage, the way that this is different from other triage systems is that there's a gray or expectant category. This category means that the patient may have a life-threatening injury, but current resources are not available to meet the need. So that's what's different with the SALT system is that there's this gray or expectant category. So here it just kind of says how they have the walking wounded, like I said. And then, like I said, those who are able to walk are prioritized last. Those who cannot follow command or who have obvious life threat are prioritized first. And those who can follow command but are unable to walk are prioritized second. So it just kind of goes through here and talks about it. But the big difference or takeaway is that there's this gray or expectant category. That means that they may have a life-threatening injury, but current resources are not available to meet the need. So that is your SALT model. Okay, here's a prioritization question. Again, this is very long and in-depth. I would highly, all capitalized, suggest that you methodically go through this prioritization question. Um, because they're liking to do prioritization questions on your exams. Also, here is another question that you guys can do on your own because it's so long and involved. I'm not going to read it. And it's talking about the START model. So please go back through here and do that question as well. Okay, terrorism. So terrorism, um, this is meant to create fear among the public, or to try to convince citizens that their government is powerless to prevent terrorism, to get immediate publicity for their causes, kidnappings, hijacks, bomb scares, bombings, biological terrorism, nuclear terrorism. I mean, it just goes on and on. Weapons of mass destruction. Um, and this can be any weapon or device that can cause death. It can be a disease, it can be an explosion, it can be a toxin or a poison. That is terrorism. Next, natural disasters. So these all speak for themselves, but earthquakes, we all know what an earthquake is, tsunami, powerful ocean wave that is a result of an underwater earthquake, and it can reach 500 miles per hour and can reach 50 feet or more, which is unbelievable to me. Tornadoes, this is what I grew up with. So 1,000 tornadoes each year in the United States. Matter of fact, in May, when I was in Nebraska for my mom's funeral, I had to go to the basement when I landed in the plane in Nebraska because we had tornado sirens going off. So that was a great joy. I was up till 3 o'clock in the morning with that. So tornadoes, um, hurricanes, cyclones, and typhoons. Says 2020 was the most active year in the US history. With this, winter storms and blizzards lived through that as well. And then heat waves, we have that here in Arizona. Okay, so potential injuries. This slide I specifically put in here so you can read through this on your own, and please have it make sense when you look at things like earthquake, um, how your potential injuries could be skull fractures, spinal cord injuries, hypothermia, wound infections, how those crush injuries could happen with an earthquake. That makes sense to me. Same thing as you go down, like with blizzard. With a blizzard, how you can have orthopedic injuries, people, falling, acute myocardial infarctions, carbon monoxide poisoning. That makes sense to me with blizzards. So motor vehicle accidents, frostbite, hypothermia, all of that would make sense with the blizzard. Um, Hurricanes here. Um, do know out of all of these, hurricanes are the only disaster that come with some sort of early warning, and you can have evacuations that occur prior to their impact. So that's the difference with a hurricane. There's actually, it's the only disaster that comes with some early warning that they can give people so they can evacuate. All right, nuclear and radiological events. Um, Here you have alpha, beta, and gamma rays. So radiation, it says basically radiation is all around us. It's present. Oh, excuse me. It's present around us all the time. People are exposed to small amounts of radiation every single day. This can can come from natural things like the sun, or from man-made sources like televisions, microwaves, X-ray exams, things like that. So just know people are exposed to small amounts of radiation every single day. So um, alpha it talks about can be stopped by thin clothing or a sheet of notebook paper, that alpha rays. Beta, here this says this can cause large quantities of beta particles on the skin, can damage the basal layer of the skin, like radiation burns are beta. And then gamma, it says can penetrate the whole body, more radioactive and can kill cells, can deliver radiation doses to the internal organs as well as the skin, resulting in damage. So those are your alpha, beta, and gamma rays. So this kind of shows this again, the difference between the alpha, beta, and the gamma rays. And then, like I already said, radiation, this type of energy is present around us all the time, and we're exposed to small amounts of radiation um, every day. Um, Here, this is an illustration again of um, radiation exposure and irradiation. The big thing on here is um, a syndrome that can occur called acute radiation syndrome. So I just want you to be aware that with acute radiation syndrome, this is an acute illness caused by irradiation of the whole body. It follows a somewhat predictable course, and it talks about symptoms and manifestations that occur with it. So clinical manifestations that can happen are nausea, vomiting, anorexia, diarrhea, fever, and then it says mild skin erythema. It says that these symptoms start within minutes to days after the exposure and can last for minutes or several days, and they can come and go. It goes on to talk about how the person usually looks and feels healthy for a short time, and then again, they'll become sick again with these same symptoms. This seriously ill stage may last for a few hours to several months followed by recovery or death. And it says that each phase of the illness varies in length relative to the radiation dose received. So again, this is called acute radiation syndrome. Here's another quick question that you guys can do on your own. Okay, an infectious disease disaster. This is biological agent or disease that may result in mass casualties. So Ebola, Zika virus, COVID-19. This is can lead to if this could be intentional. This could be called bioterrorism. So intentional use of a biological agent or derivative to inflict harm or death onto a civilian population. So yeah, this is infectious disease disaster. So high priority agents. So here it talks, there's actually more to this table. This is taken out of your book, but I want you to be aware of different biological agents that would be the highest priority. And you see here, it talks about anthrax, botulism, plague, smallpox. These are um, the highest priority, it says category A, highest priority agents. So this means that they can be easily disseminated or transmitted from person to person. They result in high mortality rates and have the potential for major public health impact. It says might cause public panic and require special attention for public health preparedness. So as you can see here, smallpox, anthrax, botulism, these are all category A patients, or I mean agents. And actually, another example, in the hospital that I had worked at previously, many years ago, we had the prison contract and we had a bunch of prisoners. I think we had a total of 8 that came to our hospital, that were making prison hooch or Pruno alcohol in their toilet using potatoes and fermented potatoes. They ended up getting botulism from it and they all died. So as they came in, this is a nerve toxin and it's bioterrorism. As they came in, you'd see them coming in on the stretcher, barely breathing. They could hardly move because it's nerve toxin. And then we would quickly have to intubate them and put them on the ventilator. And as they kept coming, probably by the 4th one, they were just intubating them right away in the ER. So it was a big deal. They took up the entire back end of our ICU, and they were all probably in their 20s. They were all high security. They had 3 security guards for each prisoner. There were murderers, and they all died. Every single one of them. The government came in, bringing in the antidote. I don't remember what it was. They had to fly it in, and it was delivered by some guy in a suit, by the government to treat this botulism. It had to be reported to the government, and it was considered bioterrorism, even though they did it to themselves. So that was kind of an interesting thing. Okay. One last thing I want to say about this is, when you have an infectious agent that's involved in a disaster and you need to keep it from spreading to others, especially if it's a respiratory illness, that could be transmitted, like when we had the COVID-19, when we had that, that's our number one example of that. All of these patients were isolated in a negative pressure room. So they went into a negative pressure room. Um, this is a nurse's priority. If there's a respiratory illness that could be transmitted like that, that's of a potentially infectious agent, that's involved in a disaster. So COVID-19, to keep them from spreading illness to others, we put them in negative pressure rooms. That was our priority as a nurse. Okay, this just talks about, again, just how there's a national response framework. You have the Emergency Management Assistance Compact, or an EMAC, FEMA. You also have FEMA, and then the National Preparedness goal. So this just kind of talks about how EMAC, how that has cooperation between the states. If the federal government gets involved, then that's FEMA, that's federal assistance. So you can have FEMA get involved and say, this is a catastrophe. And then it says for the national preparedness goal, it says to have a secure and resilient nation with the capabilities required across the whole community to prevent, protect against, mitigate, respond to, and recover from threats and hazards that pose the greatest risk to the nation. So you can read through the speaker notes there, but it kind of talks about this, the different levels, and how this makes up our matrix for disaster planning. So the national response framework, when they're making disaster plans, um, what they do is they set up mitigation, preparedness, response, and recovery. So that's the framework that they use. Mitigation is activities that eliminate or reduce the chance of occurrence or the effects of an event if it occurs. This goes on to talk about mitigation. So like maybe flood plans or roof reinforcements, things like that. Preparedness is probably what you're more used to. So this is planning how to respond when an emergency or disaster occurs. So this would be like your fire drills, your disaster drills, your evacuation plans. So we even have that as the school. This would be preparedness. Planning how to respond when an emergency or disaster occurs. So like a building has these evacuation plans or fire drills or disaster drills. And then response is the period during and immediately following a disaster. And then, of course, recovery is restoring essential services and resuming normal operations. So your national response framework, um, this is the disaster plan for the nation. And it talks about gaining control of chaos at the scene, organizing personnel and resources, and being a liaison for public information, safety, and security. With the hospital, their response to a disaster, it says to accessible, um, prepared to be able to function at maximum capacity and able to respond to external and internal events. So with this, you have to have very effective planning involved. So that means, for a hospital, they have to have appropriate PPE or personal protective equipment, decontamination equipment, process, surge capacity, evacuation plans, debriefing, how to maintain readiness. So it's just know that there's steps involved with this. So hospital preparedness, there's 4 levels. This is the PPE that the hospitals use to help keep their staff safe. So personal protective equipment or PPE. First thing you would do with hospital preparedness is identification of the hazards, and then they would have the PPE, and that would be a level A, B, C, and D. So effectively planning an emergency response requires the hospitals to address many details such as staff safety. And by doing it this way, they can keep their staff safe. Um, Identification of hazards, though, as you see it bolded there, is the highest priority in dealing with a disaster. And then it goes on to talk about these levels, level A, level B, level C, and level D. But if I show the next slide, that makes more sense there. You can see what's involved with that. So level A, as you can see, that has the most PPE. That's the highest level, provides the highest level of protection. And then there's level B, level C, and then level D. Level D protects from nuisance exposure with mask, gown, and gloves. That's the lowest level of protection. And guess what? They put all of us in during COVID-19, which was killing everybody. Right there, level D protection. So that was cute. Level D protection. But I will tell you that the people that came into our ICU and were working on the computers and making sure all of that was set up in our COVID unit, they were wearing, and I'm not joking or exaggerating. Level A and level B protection, while we sat there working in it in level C. So, true story. Level D, level D, that's what we had. So we had the lowest level of protection during COVID-19. Okay, there's another question for you to answer. Hospital preparedness continues. Decontamination is talking about removing the patient's clothing. This eliminates 60 to 90% of the contaminants. So it just kind of talks about trying to make it so those contaminants or contaminated people do not enter the hospital. The hospital must protect and decontaminate the hospital must protect the decontamination team from secondary exposure or injury. So it's very important to make sure that we have a way of providing decontamination. Also, for hospital preparedness, it talks about hospital evacuation, making sure that the most medically fragile evacuate first when there's resources to do so, how it's orderly, safe versus fast. So there's a distinct way, and they go about hospital evacuations for like fires, things like that. The nurse's role during a disaster is preparedness, response, and recovery. So effectively planning an emergency response requires hospitals to address many details, such as staff safety and the availability of PPE, decontamination equipment, and process surge capacity, evacuation plans, so on and so forth. So, like I said, it's important to cooperate and to implement all of these mandates that are brought down upon us in the hospital. Identification of hazards is the highest priority in dealing with a disaster. And then here is your last question that you will go through and do. And like I said before, make sure you go back and answer all those questions. There's a reason why I put them on here. And that is the end of your PowerPoint. Thank you.